All right, so ready to go. And again, welcome everyone to a slightly more socially distanced version of MRF HV Echo than usual. As you can probably hear in the background, the chickens are accompanying me. Again, we just want to thank everyone. We understand this is a very strange time right now in Trinidad and Tobago. A lot of us are under the effects, direct or indirect, of COVID-19 in the country. And all of us have a lot more work to do as a result of that. But again, we want to thank you for spending your time and your energy to share this session with us. And today we're very excited. Dr. Edwards is going to share some original research that was done right here at MRF about psoriasis in Trinidad and Tobago among persons living with HIV at the MRF itself. So I'm not going to preclude much of this conversation. I just want to welcome Dr. Edwards. Thanks again for your time, and you have the floor.
Okay, good afternoon, everyone. So today we're going to talk about a study that we did at the MRF of psoriasis. And for those of you who don't know, I'll share what psoriasis is, okay, in patients attending our clinic. All right, so psoriasis is a chronic immune-mediated disease, and it involves predominantly the skin and the joint. And then psoriasis has been linked to a number of comorbidities. You all hear about comorbidities and COVID. So comorbidities, psoriasis can affect the joints. You could get psoriatic arthritis. It may be associated with diabetes and heart disease and hypertension, this sort of metabolic type syndrome. And has also been associated with inflammatory bowel disease, ulcerative colitis, and Crohn's. These comorbidities have been associated with worse clinical outcomes and can negatively affect a person's quality of life. So just to show you what psoriasis looks like, you can see these silvery plaques tend to be on the extensor surface. Extensor surface means like the elbows and the forearms and the legs. You can see here the knees and the legs. You can see the elbows here, the forearms. It could also affect the trunk, as you can see. So there's these red scaly plaques with scale, It could affect the hands, as you can see there. The dorsum of the hands, you can see it also affecting the legs. It could affect the palms and soles of the feet. And you can see it on the sole of the feet there. Right. Psoriasis may affect the trunk, so it affect the back, and you can see the elbows, the extensor surface again. And you can see here on the other picture on the right, affects the chest and again the elbows. So you see the scaly reddish rash. Now, psoriasis is not contagious. Psoriasis is a condition that some people get, and it's more disturbing to them cosmetically, and it could be associated with joint pains. But the cosmetic thing is a big issue. It's not transmitted from one person to another. Psoriasis may affect the scalp. As you can see here, you can see the scaly rash in the scalp here, the red plaques, as they call it, in the scalp there. And can affect the groin area too. And usually affect the groin area because the groin area is moist. It don't tend to be as scaly, all right, as the elbows and the knees and the scalp. So psoriasis also affect the groin area, or the flexures, as they call it, and it can affect the nails. And there's some nail changes associated with psoriasis. And this is classic here. You can see the pits. You can see the nail pits, all right. You can see the lifting of the nail plate from the nail bed is called onycholysis, all right? You can see the yellow material on the nails. This is called subungual hyperkeratosis. And you can see that kind of greenish kind of spot in the nail there, and that's called the oil drop. So that's some of the classic signs of psoriasis of the nails. And psoriasis can affect the joints, and you can see you get arthritis, you get damage to the joints, all right, and deformities of the joints there. All right, so in most reviews all over the world, psoriasis is thought to affect 2 to 3% of the world's population, all right, with an equal frequency in males and females. And they did a study in the USA, and they found that the prevalence of psoriasis among adults was reported to be 3.2%. It was higher in Caucasians, 2.5%, compared to the African American, 1.9%, indicating there's an ethnic difference. The Caucasians have a higher prevalence of psoriasis than the African Americans. In terms of Trinidad and Tobago has about 1.4 million people. 35.4% of them of East Indian origin, 34.2% of African origin, 23% of mixed race, and 7.5% of all the other races, Asian, Chinese, Syrian, Lebanese, etc. Persons of African origin came to Trinidad and Tobago via the African slave trade, and they came in mainly from West and Central Africa. And they did dermatologic studies in those places in Africa, all right, in those West African populations. And it was much lower than the general parts of the world. Nigeria, 0.5%, Sierra Leone, less than 0.2%, Senegal actually won the African Nations Cup, 0.6%, and Mali, 0.02%. The East Indians came to Trinidad as indentured laborers, mainly from Uttar Pradesh and Bihar regions of North India, and a smaller number from Bengal and various areas in South India. And the prevalence of psoriasis in India ranges from 0.44% to 2.8%. We did some studies at the skin clinic at the Port of Spain General Hospital. I don't know if you all remember Dr. David Kwamina. Dr. Kwamina, he looked at all the new patients who came into the Port of Spain General Hospital, did the study in 1975, and 4% of them who attended the skin clinic had a diagnosis of psoriasis, all right? Then Dr. Marilyn Sweet, another dermatologist, was in charge of the skin clinic. She also looked at the prevalence of psoriasis of new patients being referred to the skin clinic and found that the prevalence of psoriasis was 5.1%. She also found that 50.1% of the cases were in patients of East Indian origin, and about 30-something% were in patients of African origin. And in Jamaica, La Grenade and Alabi looked at the prevalence of psoriasis in new patients coming to a clinic, and they found it was 2.3%. So, but those skin clinics may be more biased there because people with psoriasis are referred, so people with skin conditions are referred to the skin clinic. So it's a bias there, it's not a general population, all right? So we expect those prevalences to be higher. Now, in terms of skin diseases and HIV, skin conditions are maybe the first manifestation of HIV and maybe be associated with significant morbidity and mortality. I remember lots of patients presented with shingles or herpes zoster for the first time. And then when we did the test, we found that they were HIV infected, or they may have presented with seborrheic dermatitis, and then when we did the test, the HIV test was positive. So, or some of them might even presented with the skin manifestations of secondary syphilis. And then when we do the test, the HIV test came back positive. So the prevalence of psoriasis among persons living with HIV has been reported to be approximately 2 to 3%, which is actually similar to the rates of the general population. So psoriasis has been observed in all stages of HIV infection, and actually maybe the initial presentation of HIV infection. And studies have shown that the severity of psoriasis in patients with HIV ranges from mild to severe, and with more severe disease, the more immunosuppressive person is. So the lower the CD4 count and the greater the tendency towards having AIDS, greater the risk of psoriasis. And if patients have a diagnosis of psoriasis and then they afterwards got HIV infection, they found that the HIV infection exacerbated or worsened the psoriasis, okay? Studies have also shown that psoriatic arthritis, that's the joint pains with the psoriasis, is more common and severe in HIV-infected population, affecting 23 to 50%, okay? And the clinical course of HIV-associated psoriasis is described as progressive and typically refractory to conventional treatment, meaning it is really difficult to treat and therefore is a therapeutic challenge. So HIV-associated psoriasis tend to present in patients with low CD4 counts and therefore those who have an overall reduced immune system. And then many of the systemic treatments for psoriasis, so many of the tablets or the drugs or those biologics you all see on TV, all right, to treat psoriasis are immunosuppressive, all right? And then HIV is an immunosuppressive condition. So this can potentially lead to severe complications in the setting of HIV. So the studies suggested that HIV and psoriasis is not a really good combination. So that's why I decided to do the study at Mrftt. So as you all know, Mrftt is an NGO that was established in 1997, all right? And the government of Trinidad and Tobago in 2002 commissioned Mrftt to become the first treatment and care clinic in Trinidad and Tobago. And looking at our figures, as of December 31st, 2018, the number of patients registered in the clinic is 8916. The number of patients in active follow-up as of December 31st, 2018 was 65, or 73.6%. Unfortunately, we had 1,603 deaths, 18%, and 748, or 8.4%, were lost to follow-up. So looking at the figures here, if Mrftt has 8916 patients registered, and the prevalence of psoriasis worldwide is 2 to 3%, I was expecting we'd probably get, 160 to 180 patients attending our clinic, all right? So we'll see what we got. In terms of patients attending Mrftt, up to December 31st, 2018, 59.7% were of African origin, 17, 21, and 19.3% were of mixed race, and 7.8% were of East Indian origin. Now, Mrftt has about 70% of all the persons living with HIV in Trinidad and Tobago. So I would probably say from this, even though we're in a Port of Spain and the East Indian community is not, concentrated in Port of Spain, I would still say that HIV tends to affect more persons of African origin and mixed race than those of East Indian origin. So we looked at the study now to determine the pattern and prevalence of psoriasis attending the HIV clinic. In terms of inclusion criteria, we looked at patients 18 years and older, of course, persons living with HIV, and of course, patients attending the Mrftt for the diagnosis of psoriasis. We excluded patients under the age of 18, people who are HIV negative, and patients who attended the Mrftt but who were not diagnosed with psoriasis. So we did a chart review study, all right, over the period January to March 2019, all right, looking at all the patients who were diagnosed with psoriasis. This study received ethical approval from the Campus Research Ethics Committee of UWI St. Augustine. So all patients who attend our HIV clinic, if they have skin conditions, we tend to refer them to the skin clinic at Port of Spain Hospital, although I'm there now, so I can manage some of the skin conditions, all right? And then patients who are diagnosed with psoriasis, if they're found to be HIV infected, they of course referred to the Mrftt, all right? The Mrftt has an electronic medical record system called SELMA, all right? So what we did was we plugged in psoriasis in SELMA, and during the period, April 2002, when the clinic first started, to December 31st, 2018, and a list of patients with psoriasis was generated. All right, so during the period, January to March 2029, from SELMA, I was able to pull all the records of patients with psoriasis and then go through the records. And I had a little questionnaire, all right? So we asked some of these patients with psoriasis, come in and see me, all right? And then a little questionnaire and stuff to fill out. And that's what I did. So as I said, the prevalence of psoriasis was 2 to 3%. And so I was expecting, 160 to 180 patients. But look at our results. During the period, April 2002 to December 2018, 37 patients with psoriasis were seen at the Mrftt. 37 out of the 8,916 patients. In terms of males and females, now the literature says the males and females are equal in our study, we had 32 males and 5 females, a male to female ratio of 6.4 to 1. The age range and the diagnosis of psoriasis, when the patients came in, I asked them, how old were you when you were diagnosed with psoriasis? The age range of the was 13 to 70 years with a mean age of diagnosis of 37 years. So the prevalence of psoriasis in patients attending our clinic was 37 over 8,916, which is 0.42%, which is much less than, the prevalence that they in the world literature. The prevalence of patients of African origin was 0.4%, which is similar to the prevalence in those African countries that I mentioned before. And the prevalence of psoriasis in patients of East Indian origin was 0.58%, which is similar again to the prevalence of psoriasis in India. The prevalence of persons of mixed race was 0.44. And looking at the age group of diagnosis, you can see the age group 30 to 49 had 24 patients. Most of the patients were diagnosed when they were between the ages of 30 to 49. In terms of patients by ethnicity, the psoriasis patients, 56.8% were of African origin and 10.8% were of East Indian origin. Remember, I told you the study by Dr. Sweet showed that over 50% of the patients were of East Indian origin. In terms of sexual orientation, 78.4% said they were heterosexual and 21.6% said they were men who have sex with men. In terms of their status, 31 were alive, 6 were dead. And in terms of looking at the psoriasis by severity, remember most of the studies show that psoriasis tends to be severe and difficult to treat in HIV patients. In our study, 30 patients, or 81.1%, had mild to moderate psoriasis, whereas 7 had generalized psoriasis. Now, severe or generalized psoriasis is psoriasis affecting more than 10% of the body surface. If you look at the palm of the hand says 1%, so 10 palms of the hand on the body would be more than 10% of the body surface, and only 7 patients, or 18.9% of them, were considered severe or generalized psoriasis. In terms of medications used to treat psoriasis, we usually treat them with creams or we give them tablets. So most of the patients had mild to moderate psoriasis, so 35 of them got creams, and 2 of the severe patients, in addition to the creams, they got tablets, methotrexate, which is an immunosuppressive drug, all right? And then when we asked them how many improved, because remember the study showed that psoriasis is difficult to treat as an intractable disease, 83.8% of our patients said that they got a fair amount of improvement with topical therapy. Only 61.2% said they had no improvement. So our results were kind of different from the world literature. In terms of a family history of psoriasis, 1 patient, or 2.7%, said that he had a sister with psoriasis. And in terms of psoriatic arthritis, psoriasis affecting the joint pains, remember the study showed that 28 to 50% of HIV patients have psoriatic arthritis. In our study, only 2 patients out of the 37, 5.4% of them had psoriatic arthritis. So our results are a bit different from the world literature. So in conclusion, the prevalence of psoriasis in patients attending the HIV clinic was 0.42%. Those of African origin, 0.4%. East Indian origin, 0.58%, and those of mixed race, 0.44%. More males than females attended the HIV clinic with diagnosed with psoriasis. Most of the literature say the prevalence is equal in males and females. Our study was different. The studies again show that psoriasis tends to be more severe in HIV-infected patients, persons living with HIV. We found that more of our HIV patients or persons living with HIV, 81.1% were diagnosed with mild to moderate psoriasis compared to 18.9% who had severe or generalized psoriasis. And in terms of treatment, most of the studies show that psoriasis is difficult, intractable, a problem to treat. most of our patients say they actually did well. 94.6% did well with just the topical therapy alone, compared to those requiring systemic therapy. And most patients said that the psoriasis improved. 83.8% said the psoriasis improved with the topical therapy. And in terms of psoriatic arthritis, where the literature said that 28 to 50% of persons living with HIV had joint pains, only 5.4% of our patients, or 2 patients, had a history of psoriatic arthritis, and only 1 patient had a family history of psoriasis. All right, so we actually got this study published last month. All right, our study has some limitations, because the data was from an existing database. All the patients have who attended the clinic at MRF. All right, we may not be able to capture all the important information on the patients, and then the ethnic makeup of our clinical population, where we have mostly people of African origin, is totally different from the general population, where East Indians and Africans are almost 34-point-something% each. All right, and as this is a clinic that deals with persons living with HIV, the results might not be generalizable to the general population in Trinidad and Tobago. All right, so we recommend that a study be determined should be carried out to determine the prevalence of psoriasis in the general population, and we thank you. All right, and these are my references. So over to you, Dr. Boyce.
Thank you, Dr. Edwards. That was really, really fascinating. So I'm going to open the floor for any questions or comments, but just to get the ball rolling, in your experience with psoriasis in Trinidad, how often do you see that someone would have been, had a delayed diagnosis because you have a rash, you go to the pharmacy, everything is
a lot of them tend to present. I know a lot of them tend to present with a skin rash, and they would go to pharmacists, or they go to different people, or they go to the general, treat it, and then eventually psoriasis don't really go away. It goes and comes and goes and comes. So eventually, when they realize, well, this rash isn't going away, then they go to a dermatologist, and then they're diagnosed with psoriasis. So sometimes it takes a while for them to be diagnosed. As I say, psoriasis is not a condition that is transmissible, so it's more cosmetic thing. People don't like the skin to look like this. Sometimes when they sit, all the scales, or you put your hands, or you're on a desk, and you get up, you see the scales remain on the desk. So it's more of a cosmetic problem than anything else,
Thanks for that, Dr. Edwards. Any other questions, anyone?
Adding to what you asked and what Dr. Edward has said, I think about 2 weeks ago, we had a lady, a female patient, who for years, she believed that her skin condition was due to a reaction to antiretrovirals. So much so that she was really, really, I think, against using Truvada because she thought she was reacting to that. I think Dr. Edwards remembers, he reviewed her a few days ago.
Yeah.
And then when she went and she's been on topical steroids, systemic steroids with marked improvement, sometimes the skin is horrible. And then she had a skin biopsy the other day that confirmed that she actually has psoriasis. Now, my question to Dr. Edwards, these patients that we have at MRF diagnosed with psoriasis, is the diagnosis clinical or is confirmed by histology?
Usually, I mean, we can make a diagnosis of psoriasis clinically, you don't really need a biopsy unless it's strange, So okay. It's classic. Remember I showed you the photos. So, most people, you can look at psoriasis and make a diagnosis. If you worry about it, is now coming on, or if you're using treatment and the steroids, it may change a bit, then you may do a biopsy. But usually we can diagnose psoriasis clinically in most patients. So once we send them to the skin clinic, they will diagnose them clinically.
Yes, you had a part two, Dr. Musa?
No other comment currently.
I know most patients, most of the audience would know about psoriasis. So I don't expect too many questions, you know,
Sure, no problem.
unless they're a relative with it, you know.
Sure. Okay, so I think with that said, I think again, I just want to thank Dr. Evans again for the wonderful presentation. And we'll move on to the clinical case. So again, I'm at home. So let's see. Wait, we have a question from Ingrid, from Ms. Marcelin. Is there a correlation between the level of immunity and severity of disease, Dr. Edwards? I think you touched on
Yeah,
that.
so most of the studies have shown that the worse the immune status, the more severe the psoriasis. But what had happened in our clinic is because we started treating everybody. Remember, we started in 2017. So we started treating everybody with psoriasis now. So, I mean, they're doing quite well. Is it the antiretroviral therapy helping the psoriasis, or I mean, and the improved immunity? You know, don't know. You know, but it's difficult to say. But studies have shown that the more immunosuppressed the person is, the worse the psoriasis is. We didn't really see that in our study, but again, we started antiretroviral therapy to all patients in 2017.
You describe our last patient, but she seems to have very, very bad relapses. And yet she has a CD4 cell count of about 1,082, and viral loads have been undetectable for a very long time. So it seems
again, that's what I said. Yeah, from our studies, it didn't bear out what the literature said, that psoriasis is intractable and stuff in patients with low CD4 counts. We didn't really see that, you know.
Again, thanks for all the very good questions. So we'll